Hello, and welcome to the Mimosa Matters podcast series. In this series, we will bring you interesting perspectives on the clinical, research, and technological perspectives for near-infrared spectroscopy imaging, or NIRS, and introduce you to Mimosa Diagnostics. I'm your host, Douglas Queen. Today, we're bringing you a Mimosa Matters poster chat, where you can learn from our collaborators about their important research. Thank you for tuning in and joining us on today's podcast. We will be hearing from Stephanie Furtado. She's a clinical nurse specialist for wound and ostomy care at Hamilton Health Sciences. She's also a graduate of the Western University's Master of Clinical Science in Wound Healing. She has been working as a nurse specialised in wound, ostomy and continence since 2016. She is also a faculty lecturer for McMaster University Department of Surgery and helped to create the NSWAP Pediatric Community of Practice. She's passionate about providing quality patient care. We also hear from Stephanie Rintoul. She is a Clinical Innovation Coordinator at Hamilton Health Sciences. In her role, she project manages the evaluation of health technologies with HHS Hospital Network, as well as identifying new project opportunities. Stephanie is a Certified Associate in Project Management and holds a Master's in eHealth and a Bachelor of Science. Welcome, Stephanie F.
Hi.
And welcome, Stephanie R.
Hi, Douglas. Thanks for having me.
Let me start our conversation by asking you a few questions about your poster entitled Driving Health Equity and AI-Powered Imaging Technology for Early Detection of Pressure Injuries, such that our listeners can get some insight into your experience with NIRS imaging. Stephanie F., tell our listeners a little bit about the background of this study.
So probably in late 2021, 2022, we had a small group of clinicians that were noticing an unfortunate trend in patients with dark skin tones, that they were more likely to have a pressure injury get worse before anyone on the healthcare team noticed. So we were catching these at stage 2 or stage 3 pressure injuries and not catching them at stage 1 pressure injuries, and that it was particularly prevalent in patients with dark skin tones. The staff member that brought it to myself and the patient safety manager was expressly frustrated because she said she had brought this forward to other leadership several times over the years and had never gotten any buy-in to do anything different to make it better for those patients with dark skin tones. So we, made a very conscious decision that we weren't going to ignore this problem, and we were going to see what we could do to improve for patients with dark skin tones, the assessments and care that we provide to make sure that we weren't waiting for them to get a worse outcome before we noticed and did anything differently for them. We started with a very brief literature review. We wanted to know what was out there, what we should be doing. We did come across some key best practice guidelines that had been released by a couple areas, but that entry to practice, that kind of knowledge translation, hadn't really occurred, and those concepts were not being used in clinical care at this time, even though they had been well documented and started to be released. While we were looking at how to do a better assessment, we were also looking at the best practice guidelines that started to talk about this new technology wave. Particularly, we were first looking at thermal cameras and imaging, and then I became aware of the near-infrared technology and the oximetry aspect of it subsequently. But at first, we were really trying to understand, how could this be a benefit to us? What was available in Canada? What would work with our electronic medical record? And it was actually one of our surgeons who flagged us to Mimosa and said, hey, I have this friend, Karen Cross. She's created this fantastic thing. Maybe you guys should start to explore this. So I reached out to Mimosa with the support of our leadership to start the discussion to understand, hey, how could this technology meet this need that we had identified clinically?
Great, well, thank you. Stephanie R., the initial results from your pilot over 4 months involved 3,500 assessments, which is a really good data set. What have these shown?
Yeah, so as you mentioned, Douglas, it's quite a large data set and actually one of the largest prospective studies in imaging within the wound care space. And so we're quite happy with the scale of it. And we also were able to collect data across diverse clinical settings. So we had surgical patients, complex care, ICU. However, there is some work to be done on collecting more images for our dark skinned patients, and that will sort of be a phase 2 to the project. But focusing on the results that we have so far, we were able to do 2 different types of analyses. The first one is a kappa test, and that really looks at the level of agreement between 2 different tools. So for our purposes, between the MIMOSA Pro and the Braden Scale for adults and the Braden QD for the pediatric population in terms of what they're outputting for risk level. And what we saw is that within the pediatric population, these tools were classifying patients quite similarly. So there wasn't anything sort of different or interesting there. But in the adult population, this is where we saw Braden and MIMOSA categorizing patients differently. And this could be because Braden QD, which is our pediatric tool, is a little bit more recently updated than the Braden scale, so that could be the reason. But we really wanted to understand what this all meant clinically. And to do that, we needed to dive a little bit deeper with the specificity analysis. And a specificity analysis tells us how well the tools are at correctly identifying patients are not at risk for developing PIs. And what we saw, again, in the pediatric population, there was nothing different there. MIMOSA and Braden were both high specificity, greater than 90%. But in our adult population, we saw that MIMOSA significantly outperformed the Braden scale. So MIMOSA was at a specificity of greater than 91%, and Braden scale was closer to 40%. And what we really drew from this was the MIMOSA Pro has the potential to reduce unnecessary interventions for patients. So to really avoid using hospital resources when it's not necessary, to avoid unnecessary patient discomfort. So this was a really interesting, significant finding. And I just wanted to highlight that for this trial, we were unable to do what we wanted, which was our sensitivity analysis, which would have been the opposite of our specificity analysis. And this would have told us how well the tools are at correctly identifying patients are at risk for developing pressure injuries. And part of the reason that we could not perform this specific analysis is due to the intervention bias. So whenever the MIMOSA Pro or the Braden tool showed that there is a risk for a patient developing pressure injury, our clinical teams immediately intervened. And throughout this whole project, we really had to balance focusing on patient care while still being able to evaluate the tool and demonstrate the value of the solution and understand how to implement it within standard practice. So it really was a give and take between those different factors throughout the whole project.
Great, thank you. So Stephanie F. Stephanie R. mentioned that the Braden and the Braden QD are routinely used, but can be subjective, particularly in patients with darker skin tones. What was the benefit of MIMOSA Pro in your experience?
I mean, the MIMOSA Pro is showing you what is actually occurring. Braden risk scales, whether it's the pediatric or the adult, they're looking at generalized holistic factors. So they're not narrowing down into a particular area. So it'd be overall, how's the patient nutrition? Overall, how is the patient moving? Overall, so it's all of the risk assessment scales that we have as standard of care currently are very global, generalized concepts. What the benefit of the MIMOSA Pro is it was looking at this specific area, a small area over a bony prominence under a medical device across skin tones, across patient populations and ages and risk factors. And it was showing us there is something right here. And sometimes, especially with scar tissue, it was lighting up like a Christmas tree. This exact area has less blood flow than the surrounding tissues. This exact area has inflammation or ischemia starting. And this, not just that it's there, what percentage is it? This is 30% blood flow, and this is 60% blood flow in the adjacent tissue. So it was that quantifiable data that I think could be really clinically relevant to say, it's not just that, oh, this person may be at risk of getting a pressure injury in the next couple of weeks. It's, hey, this left foot has a scar from 10 years ago and already has compromised blood flow. Let's make sure that this left foot has pressure injury prevention strategies put in place, that they have pressure injury, offloading with medical devices. And so being able to specifically say this person in this area needs these additional resources. that was really unique and interesting.
Okay, as a follow-up to that question, with the MIMOSA Pro, how was the difference in the image in respect of patients with lighter skin tones and those with darker skin tones?
I don't believe there was one. I know we did trial it, and I know MIMOSA Pro team had talked about a little bit about their validation of the technology across skin tones, and I know we did specifically have some of those questions from that same team member that brought the concern forward in the first place. She was involved in some of these days when we had the MIMOSA team on site with the device. And so we were, asking those questions about how is this better than, let's say, temperature oximetry that we now understand does have a bias in how the technology was created in terms of giving false readings for patients for stat numbers. And so we definitely asked those specific questions and worked through with the MIMOSA team that this was validated across skin tones.
Excellent, thank you. And another question to you, Stephanie F. Focusing specifically on Hamilton Health Sciences needs, can you describe the EDI aspects of the project?
So with the other part of this project, with our initial skin assessment and kind of doing that entry to or research to practice piece, and rolling out better standards for an overall skin assessment standard, we have really been focusing on how do we make sure that equity, so giving patients that are at higher risk, higher need, more intensive support and services is occurring, and that those who need it more are getting it more. And so that concept of equity-based care is something that, as we've been talking through this skin assessment and rolling it out, and some of the early conversations around MIMOSA as well, in terms of how many of these do we need, and who's going to benefit, and which patient populations do we need to use it on. From this study, we don't have enough of that data to prove it for the MIMOSA side, but what we have already rolled out from our enhanced skin assessment, it's been quite clear that you do have to provide equitable care, which does mean doing things differently based off of patients' skin tone. Making sure that it really comes down to their skin tone rather than ethnicity or identified ethnicity, or someone, looking at themselves and saying, oh, I'm a light or I'm a dark skin tone, and using a validated tool to justify which patients are qualifying and counting as quote unquote dark or light. That piece has been met with some people being very excited about it, and some people feeling that even to provide equitable care feels racist to them, that because they're doing something different for patients, and there's been a perception amongst some staff that, oh, if I do this differently for this patient versus that patient, they're going to think I'm racist. And so we're having to take a step back and do a lot more teaching around the concept of equity and equitable care, and how this enhanced skin assessment, and then when we have more devices and more data for the MIMOSA Pro, that which patients are getting this scan routinely versus which patients might get this as more as an offhand. How are we going to create this care plan, this order set, who gets what resources, and bringing that equity focus in involves a much deeper and wider conversation. And I think we were a little bit surprised at first by some of those comments and feedback, that to provide equitable care was being seen as racist. And so that wider discussion about why are we doing things differently than we've always done them, those discussions still need to be had for sure.
Excellent, very interesting. Stephanie R., what are the next steps in the project now the pilot is complete?
Yeah, so there's a few next steps that we have. The first one is to continue to share our findings more broadly. So we had the pleasure of presenting at Wounds Canada. We have an upcoming presentation at CECLIPS, and we put in applications for a few other conferences as well. We also have a publication that's sort of in the works. The other next step for us is to integrate MIMOSA Pro with our electronic health record Epic, and also to integrate MIMOSA with our clinical workflows and understand how it can fit effectively with the Braden scale, and as Stephanie F. mentioned, how we can do some of that education and have those difficult discussions, which really come with any change management, any change in workflow. We also have been working very closely with MIMOSA team. Specifically, Chris Budu and Anna Kimchenko have been excellent partners throughout this whole project, and we're working with them on our next iteration of data collection. So that will involve recruiting patients with dark skin tones and really putting a focus on that and trying to build out our sample size for that specific group to understand more effectively how MIMOSA Pro can address some of these concerns for high-risk patients in our high-risk clinical areas. And just wanted to highlight that this project is really a great example of how innovation can help hospitals sort of take that next step forward in advancing patient care and build on all of that pre-existing work that HHS has already done in the pressure injury space. And so it's been a really great collaboration and look forward to continuing it further.
Okay, well, thank you very much. That's all my questions for today. So thank you, Stephanie F.
Thank you for having us.
And thank you, Stephanie R.
Thanks, Douglas.
Thank you, Stephanie F. and Stephanie R. for giving our listeners an in-depth insight into your poster demonstrating health equity in the management of pressure injuries, including NIRS imaging. Well, that's our podcast for today. We hope you've gained some new perspectives on NIRS imaging and its utility in wound management. Be sure to visit MIMOSA Diagnostics at www.mimosadiagnostics.com and visit our social media channels. Add your comments and learnings. We want to hear from you.